Department of Cardiology will be presenting a rare case of electrical storm in yellow patient. Dr. Manohar will present the case and later Dr. Narayan will discuss. Come.
Thank you, ma'am. Good afternoon, one and all, and I'll be discussing the case. Our patient is a 59-year-old female, resident of Agra, was brought to our emergency in a state of shock and altered sensorium. Going on to the detailed history, she had non-bilious and non-projectile vomiting about 10 episodes per day for 2 days, 1 week before presenting to us. She later on developed recurrent episodes of loss of consciousness in a span of 1 week, each of these episodes lasting for 1 to 2 minutes. These episodes were non-exertional and they were preceded by sudden onset palpitations. There was as such no episode of clouding of consciousness, no specific trigger, nor history of any tongue bite or posturing. These episodes were more suggestive of syncope than seizures. With these complaints, she visited 3 private hospitals and received 4 DC shocks for possible episodes of tachyarrhythmias. She later on started having high-grade fever with altered sensorium and shortness of breath, with which she presented to us in altered sensorium and shock. When she came to our emergency, she was drowsy with cold extremities. She had dry skin, coarse facies. There was yellowish discoloration of skin, palms and soles with characteristic sparing of sclera. She also had hoarseness of voice. On examination, she was found to be in bradycardia with a heart rate of 56 per minute, which was regular. She had a blood pressure of 80 by 40 millimeters of mercury in right upper limb in supine position. Respiratory rate was 22 per minute. She was hypothermic with a temperature of 96 degree Fahrenheit. She was having mild desaturation on room air and she was kept on 2-liter oxygen by face mask and she maintained a saturation of 96%. She had elevated JVP with normal wave pattern. She also had pedal edema and facial puffiness. There was no pallor, cyanosis, clubbing or lymphadenopathy. Systemic examination, precordial examination was essentially normal. There was no murmur. Respiratory system examination revealed right infrascapular coarse crepitations. Bilateral air entry was equal. Per abdomen examination was essentially normal. There was no evidence of hepatomegaly. CNS examination, she was drowsy, apathetic. There was delayed ankle jerk reflex. Bilateral plantar reflex was flexor. There was no motor weakness or sensory abnormalities. ECG, which was done immediately after examination, as shown here, shows sinus bradycardia. With a rate of around 60 per minute. There were low voltages as defined by less than 5 mm in limb leads and 10 mm in precordial leads. There was prolongation of QT interval. QT is defined as onset of QRS complex to end of T wave. Here the QT interval is measured by a tangent method where a tangent is drawn along the downslope of T wave and the point where it touches the baseline would be the QT interval. QTC corrected to the heart rate by the Bayes correction is 600 millisecond, which is markedly prolonged. For an adult female, it should be less than 460 millisecond. There was also evidence of T wave flattening diffusely in limb as well as precordial leads. There was also prominent U wave seen in the precordial leads. One of the ECG done later also shows similar changes of low voltage complexes, bradycardia, but there is also an occasional VPC. The importance here lies in the fact that this VPC is falling almost onto the T wave. This phenomenon known as R on T phenomenon is a high risk condition and this VPC can predispose to ventricular tachyarrhythmias. The chest X-ray which was done subsequently showed mild cardiomegaly with a CT ratio of 0.6. There was bilateral middle and lower zone infiltrates with possible consolidation in the right lower lobe and there is also blunting of bilateral CP angles suggestive of mild pleural effusion. We have gone back and reviewed the ECGs for which she received DC shock. This is one of them. This ECG is actually showing tachycardia with a heart rate of around 300 per minute. The QRS complexes are wide and they are regular. So basically this is a regular wide complex tachycardia and there is evidence of AB dissociation as you can see here in the circles. So AB dissociation is the dissociation between the P wave and the QRS complexes and on the background of regular wide complex tachycardia would suggest a ventricular tachycardia. With respect to the ventricular tachycardia morphology, there is LBBB with negative QRS complexes in lead 1, and there is inferior axis as depicted by the positive QRS complexes in lead 2 and lead 3, and the QRS transition is occurring at lead V4. This possibly suggests that the tachycardia might be originating from the right ventricular outflow tract. When we look very closely into lead 1, you can see that the rate, as I said, is around 300 per minute. There is no clear isoelectric baseline, and the QRS, P and T waves are not clearly separable. So this is rather a ventricular flutter rather than a monomorphic VT. So by clinical examination and clinical features and physical examination, patient is having mixed edema, and there is a background ECG which is showing long QT interval, and patient presents to us with electrical storm with recurrent ventricular tachycardia in a state of altered sensorium and shock. So this led us to suspect that there might be an underlying hypothyroidism with possible stressor or some other abnormality which might have precipitated these conditions, like electrolyte abnormality or drug related. We then reviewed the previous medical records of the outside hospital, and then we came to know that the patient is a known case of hypothyroidism on thyroxine replacement therapy for which she is non-compliant. TSH, which was done in one of those hospitals, also showed a very low TSH value of 0.01 and also a documented episode of hypoglycemia of 33 mg per deciliter. There was also evidence of dyselectrolytemia in the form of hyponatremia, hypokalemia, and hypocalcemia. One intriguing thing from these medical records is that patient on examination has mixed edematous features, but the TSH is very low. Mixed edema is usually because of primary hypothyroidism, but here in such a case the TSH should be very high. But here the TSH is low, which led us to think that this might be secondary hypothyroidism or a central cause of hypothyroidism which might be there. So to look into the cause of central hypothyroidism, we dig deeper into the history, and then we came to know that the patient had postpartum hemorrhage 29 years back in 1990 during her last childbirth, when she had excessive bleeding which required multiple blood transfusions, and also subsequently she developed lactational failure and secondary amenorrhea. During the subsequent years, she also had multiple hospital admissions with complaints of fever and vomitings. In one of the episodes in 2017, when she had this fever and vomiting, just like our presentation, she also had loss of consciousness with posturing and had undergone brief episode of CPR. She was wrongly diagnosed as having seizures and was started on phenytoin for the same, which was later stopped. So with a background of significant history of postpartum hemorrhage requiring multiple blood transfusions, with history of lactational failure in the postpartum period, and later on going on to develop secondary amenorrhea, and now patient presenting with mixed edema and also documented low blood glucose, we thought of a syndromic diagnosis which could explain everything. So we thought of hypopituitarism and possibly secondary to Sheehan syndrome. Then we started investigating for the cause. The initial baseline investigation showed that the patient had raised TLC with neutrophilia, possibly related to her aspiration pneumonia. She also had raised SGOT as well as SGPT. This might probably be because of the ischemic hepatitis which she might have sustained during the time of DC shocks and ventricular tachycardia. One thing here which was important here was the bilirubin value. The bilirubin was normal with a value of 0.85 and the patient was yellow. The patient had yellowish discoloration of skin, palms and soles, but there was sparing of sclera. And with a background of normal bilirubin, this was suggestive of carotenemia rather than jaundice. Electrolyte testing revealed that the patient had similar electrolyte abnormalities as was present in the outside hospital with hyponatremia, hypokalemia, hypocalcemia and hypomagnesemia. BNP was also markedly elevated with a value of 2700, suggestive of congestive heart failure, probably related to the shocks as well as ventricular tachycardia. She also had a markedly raised CRP of 166, again related to her aspiration pneumonia. We investigated for her hypopituitarism. Initially, the thyroid function tests have revealed that the TSH value is near 0 and with a low T3 with a normal T4. The normal T4 in this scenario couldn't be explained straightforwardly, but probably the patient might have received thyroxine even before coming to our hospital. The other anterior pituitary hormones which were done to check for the other axis of anterior pituitary were all low. The gonadotropins, FSH and LH, IGF-1 of growth hormone, prolactin, ACTH were all low, suggestive of pan-hypopituitarism. Even the end organ hormones like cortisol was 4 microgram per deciliter, which is inappropriately low for the stress state which she is having. Estradiol was also low for her age. So this was suggestive that the patient had pan-hypopituitarism, probably secondary to the Sheehan syndrome, which she might have sustained during her last childbirth. Echocardiography also revealed moderate LV dysfunction with an ejection fraction of 35% with global hypokinesia. There was mild PAH, there was mild MR and TR, probably related to the CHF which she had or LV dysfunction. There was no evidence of pericardial effusion. So, with the preliminary diagnosis, after considering the clinical history, physical examination, and the laboratory investigations we have come to a preliminary diagnosis that she has electrical storm with recurrent ventricular tachycardias, probably secondary to long QT syndrome with moderate LV dysfunction. All these changes caused by pan-hypopituitarism presenting as myxedema and adrenal insufficiency and aspiration pneumonia due to her dip in sensorium. With these diagnoses in mind, we went ahead with the treatment. We have started her on tab-mixelitin, which is a class 1B antiarrhythmic agent. Though amiodarone would be the drug of choice in case of electrical storm, because of the background hypothyroidism which she has and also prolonged QT, we preferred mixelitin over amiodarone. For her hypothyroidism as well as hypocortisolism, we have started her on injection hydrocortisone of 100 mg, followed by high dose of thyroxine of 400 microgram, a bolus dose followed by 100 microgram OD. IV antibiotics were also initiated for her aspiration pneumonia, and potassium, magnesium and calcium corrections were done accordingly. Within 12 hours of starting the treatment, there was dramatic response in her general condition. Her sensorium has improved such that she has become coherent and oriented by now, and her hemodynamics have also dramatically improved. She presented in shock with a blood pressure of 80/40, and it improved to 110/70 even without the help of inotropes. There was also improvement in her urine output, and she had urine output of 50 ml per hour subsequently. ECG, which was done 2 days after initiation of therapy, when her electrolytes have completely normalized, shows similar changes as before. That is, there was sinus bradycardia, there were T-wave inversions, there are still some low voltage complexes, but we can see here that the QT interval has markedly decreased from 600 millisecond to 480 millisecond. But again, the normal QT interval for an adult female would be less than 460 millisecond, and it still is in the higher range, which suggests that the underlying hormonal deficiency which she has might be a contributory factor for the baseline QT prolongation. With all these things, we have gone ahead to confirm the diagnosis of central cause of hypopituitarism, and we have done MRI pituitary, as well as to rule out structural cause for ventricular tachycardia. We have done cardiac MRI. To discuss this, I would like to call Dr. Neeraj to discuss the MRI pituitary as well as cardiac MRI.
Thank you. Good afternoon, everybody. So as we can see in these images, if you see the sagittal image, this is the pituitary fossa, and usually this is the location where you expect to find the pituitary tissue. But as we can see in the sagittal T2 weighted image as well as the coronal T2 weighted image, instead of the pituitary tissue, we can see that CSF is filling this pituitary fossa. Normally, this just below the optic chiasm, you will expect to find the anterior pituitary tissue, which is absent, and the fossa is filled with CSF. On the T1 sagittal image, you can see that the posterior pituitary bright spot is maintained, but again the anterior pituitary is not seen, and it is again replaced by the fluid signal intensity. So this is the characteristic appearance of an empty sella syndrome, where the anterior pituitary is, the tissue is absent and the posterior pituitary is maintained. Okay. Should I repeat or should I just? Okay. Okay. So the cardiac MRI which was done on the T2 weighted images, the one in the upper right corner, you can upper left corner, you can see that in the T2 weighted images, these are the 4-chamber images and these are the short axis images. There is, no hyperintensity is seen on the background myocardium. No evidence of any hyperintensity suggestive of edema is seen in the T2 weighted images. These are the phase sensitive inversion recovery images. These are the short axis images, the 2-chamber images as well as the 4-chamber images. You can see that the myocardium is uniformly nulled and there is no hyperintensity which is seen against the background of the nulled myocardium. So this effectively rules out any fibrosis in the myocardium. Still, to be on the safer side, we perform a parametric T1 mapping as well as a T2 mapping to look for any interstitial edema or interstitial fibrosis which may have been missed on the preliminary morphological images. But again, in this parametric mapping images, you can see that the mapping, the color map which we have obtained of the myocardium is uniformly blue, which is expected in a normal myocardium, and no amount of, you do not see any hue of orange which would suggest an edema in a T2 map or a fibrosis in a T1 map. So effectively, we ruled out any structural causes of these arrhythmias with this cardiac MRI. Thank you.
Thank you, Dr. Neeraj. So the MRI pituitary was suggestive of empty cella, and cardiac MRI did not show any structural abnormality which might have caused ventricular tachycardia. So with the final diagnosis of electrical storm with recurrent ventricular tachycardia due to prolonged or long QT syndrome with moderate LV dysfunction and an acquired empty cella secondary to Sheehan syndrome presenting with pan-hypopituitarism in the form of myxedema coma, adrenal insufficiency and hypogonadotropic hypogonadism and aspiration pneumonia was made. The course in the subsequent hospital course was uneventful. Shock has completely resolved. There was no recurrence of ventricular tachycardia further. Sensorium has completely improved and patient started ambulating. She had dramatic response not just in her history, in her findings, but also she had dramatic change in her appearance as well. This was the initial keratoniemic picture which she had, but within the next 15 days by the time of discharge, the keratonemia has completely disappeared, and in the recent follow-up during this month has shown that there was no subsequent recurrence of keratonemia, and patient had improvement in her overall general condition and was performing her day-to-day physical activities normally. The lab investigations which were done have also improved. The leukocyte count has come down after treatment with IV antibiotics. The SGOT and SGPT, which were dramatically raised initially, have also come down, possibly suggesting that this was related to the ischemic hepatitis. Electrolyte abnormalities have also normalized. TSH, the free T4, which was done subsequently to monitor the patient for central hypothyroidism, is in the normal range during her follow-up visits as well. X-ray has also shown improvement in her consolidation, and also the bilateral pleural effusion which she had has also disappeared. ECG, which had low voltages, sinus bradycardia and a markedly prolonged QT interval, has also come down by the time of discharge. The rate has improved to 80 per minute and the QTC has come down to 410 milliseconds corrected by Bezets by the time of discharge. In the subsequent visit during this month, the QRS voltages, as you can see, have also improved when compared to the baseline ECGs. Though the rate still remains at 60, the T-wave inversions which were there have also come down. And the QTC has also stayed at normal range with a value of 400 milliseconds. Echocardiography has also shown improvement. She had moderate LV dysfunction at presentation, which improved to mild by the time of discharge, and in the recent follow-up visit, it has totally normalized with an ejection fraction of 53%. So this case demonstrates a rare and a very late presenter of Sheehan's, which presented with electrical storm because of underlying prolongation of QT by hypopituitarism, which was precipitated by electrolyte abnormalities due to the recurrent vomitings which she had, which caused hypokalemia. So this is what we want to bring up, that not just electrolytes and drugs, but rather there are other causes which can cause QT prolongation, which can cause other abnormalities, which can precipitate ventricular tachycardias in such cases. Now moving on to the review of literature, what is an electrical storm? Electrical storm is defined as 3 or more sustained episodes of ventricular tachycardia or ventricular fibrillation or appropriate shocks in a patient who has been inserted an ICD within a span of 24 hours duration. Triggering mechanism is identified in only a small subset of population of around 10 to 25%. Risk factors are generally ischemia or infarction, but severe LV dysfunction, chronic renal failure, Electrolyte and metabolic factors such as in our patient and old age can also be precipitating electrical storm. Most of these arrhythmic episodes are monomorphic VTs. Approximately 86 to 97% of the patients have electrical storm with an underlying monomorphic VT, but VF alone, mixed VT VF can also occur. Polymorphic VT or torsades presenting as electrical storm is less common, with only 2 to 8% of all the electrical storm cases. Amiodarone, as discussed, is the preferred drug until and unless it is contraindicated, such as hypothyroidism or in cases with prolonged QTC, which our patient had. So the obvious second choice was a class 1B antiarrhythmic, which includes lidocaine or mixalytin. Mixalytin is nothing but a structural analog, oral analog of lidocaine. These should be used or can be used in patients who have hypothyroidism or a prolonged QTC because these do not affect the QT interval. With regard to cardiac involvement in Sheehan syndrome, it is rare. Dilated cardiomyopathy and congestive heart failure have been described in most of the cases. Panhypopituitarism presenting with ventricular tachycardia is an extremely rare phenomenon, and there are only few case reports of panhypopituitarism presenting with VT. Sheehan syndrome, a cause of panhypopituitarism presenting as VT, is even a rarer phenomenon with only 3 case reports published in literature. These are the review of all the cases of ventricular tachycardia and panhypopituitarism, and the cases highlighted in the red box are those cases where a Sheehan syndrome patient presented with VT. Most of these cases had history of postpartum hemorrhage at least 10 years back, and these patients either presented with polymorphic VT or monomorphic VT. So, how QT interval is affected by hypopituitarism? The hormone most widely known to be associated with VT is thyroid hormone. How does it does so? So, it is by slowing down the conduction of electrical stimuli, prolonging the QT interval, thereby causing torsades or polymorphic VT. Rarely, glucocorticoid deficiency is also associated with ventricular tachycardia, though the mechanism is not clearly known. Loss of maintenance of calcium transport as well as downregulation of potassium ion channels can cause VT in such patients. Occasionally, the catecholamines released during the episodes of hypoglycemia, which these glucocorticoid deficient patients might have, can also cause VT in them. So, the causes of VT in such a patient of Sheehan's could be because of dyselectrolytemia, which is the most common cause, either by hypokalemia or hypomagnesemia, QT prolongation, either by the electrolyte abnormalities which these patients have, or by the hormone deficiency per se, like hypothyroidism or hypocortisolism, and dilated cardiomyopathy or reversible LV dysfunction, which these patients can have, can also be a substrate for re-entry and cause VT in them. All these 3 mechanisms were present in our case and might have contributed to VT in our patient and subsequently electrical storm. In conclusion, this case demonstrates a very rare case of electrical storm in a patient secondary to Sheehan syndrome. History and physical examination were the clinchers in our case, and they are critical, as in our case, to every case in the diagnostic process, and often provide more information than can be obtained by any laboratory investigation or diagnostic testing. TSH on the background of myxedema was the clue for the central cause of hypothyroidism, which subsequently made us think about the cause of central hypothyroidism and the diagnosis of Sheehan's. Hypopituitarism should also be considered as a cause of ventricular tachycardia secondary to prolonged QT, which these patients per se can have, other than dyselectrolytemia. Vomiting or any stressor which these patients, because of glucocorticoid deficiencies, can precipitate VT or electrical storm in such patients, and should be carefully looked for when these patients present with ventricular tachycardia or a prolonged QT. Thank you. Now I would like to call upon Dr. Naran for his comments.
Thank you, Manohar. So, we presented this case because of its rarity, as was shown that there are only about 3 cases of VT due to Sheehan syndrome that have been documented. There are about 3 more who have got panhypopituitarism, not because of Sheehan, they also resulted in VT. And but at the same time, we also would like to bring to attention through this case that the thyroid function is really involved in a big way in the heart. It's in a subtle manner that its involvement is there, but it should not be ignored. And otherwise, for example, in this case, it took 30 years almost for this patient to be diagnosed as Sheehan syndrome. So there are a lot of recent studies on thyroid hormones and the heart, and even in the normal range, thyroid hormones are known to affect the cardiac function, the ECG changes. So during in the normal range also they have got an effect. TSH is a single factor which is predictive of cardiac events. Both low TSH and high TSH, they are associated with increased events. Even a subclinical hypothyroidism, like the TSH between the 4 to 7 range, that is also associated with increased event. That studies have shown. Low T3 is another factor. If patients who come with low T3 alone, they are also associated with higher cardiac events. So we need to have keep a watch on this. Higher levels of T4, of course, with atrial fibrillation, they have been associated. And recently, the Mendelian randomization studies have been done for a number of scenarios to determine the causal association. And hyperthyroidism has been causally associated with atrial fibrillation in those studies. In some cases, cardiac devices are being increasingly used, and there was a case report where the device capture was not the lead capture was not there in patient hypothyroidism, and that started capturing after correction of the thyroid status. So genetic studies are also there, and people are also trying thyroid hormone analogs in treatment of cardiac conditions. So thyroid hormone is an area which is very extensively being studied and will become even more important in the future. I request Professor Rajesh Khatgawar, Professor Endocrinology, to give his comments on this case.
Thank you, sir. It's really pathetic to see a diagnosis of Cushing syndrome diagnosed so late, where careful history can easily make diagnosis. History of postpartum hemorrhage. Most of these cases usually require IV fluid therapy, or they require blood transfusion. And lactational failure is so typical of this condition, and most of the patients, maybe 80 to 90% of patients present with lactational failure. And this history combined with secondary amenorrhea usually diagnose Sheehan syndrome, which can be confirmed with the endocrine investigation. If we take in all these cases, take careful history, even in the emergency, these cases can be easily diagnosed. Regarding cause of ventricular arrhythmias, it would be difficult to see that severe hypothyroidism alone is causing this ventricular arrhythmia. We are not seeing these type of, we are seeing severe to severe cases of primary hypothyroidism, but we are not seeing any ventricular arrhythmias. Or so much so that while preparing for this case, we have checked our textbook also, they haven't mentioned that there is a QTC prolongation in hypothyroidism. So it's not alone hypothyroidism, it's a combination of hypothyroidism, hypocortisolism with dyselectrolytemia might have caused this QTC prolongation and ventricular storm. Fortunately, this patient was managed well and corrected easily. All electrolytes abnormalities were corrected. And treatment of Sheehan syndrome is very gratifying, very easy. Usually, we do not go for apart from thyroxine and cortisol replacement. Two other axes, like we can go for growth hormone replacement, or we can go for hormone replacement therapy for gonadal axis. But most of the ladies present late after 50 years, so these two therapies are not practiced. So just give thyroxine along with the prednisolone or dexamethasone. Usually they do very well. And this lady has improved on hydrocortisone, and subsequently she can be shifted to prednisolone. Thank you.
I'll invite any questions from the faculty of this branch. Go ahead.
So I have a question. Sir, what do you take on, suppose the patient comes with the CAD, as you said about dioxin and all, the patient comes with CAD, needs surgery, and theoretically suppose the patient has adult thyroiditis, some clinical hypothyroidism. If the patient is stable and not a critical lifting, what is your take on that patient, sir, regarding the timing of surgery?
So obviously, if it is not an urgent surgery, one would like to correct the hormone status before taking up the patient for surgery. Of course, one has to balance the urgency of the surgical procedure versus the severity of the hormonal imbalance. So depending on that balance, one will have to decide which one to do first.
This patient was on thyroxine, I think, and he was diagnosed as hypothyroidism earlier also. So what was the level of thyroid?
So, as such, we don't have any investigations previously, but the documents which were present outside had shown that she has hypothyroidism, nothing like primary or secondary, and she was given Eltroxin, which the patient was non-compliant to. This was the only information which we have. Probably they might not have thought it as central hypothyroidism, otherwise they would have worked it out. So only based on, we don't know what exactly they have done, but
Just in case, recommended if patient has hypothyroid, do not delay CABG for hypothyroid. It can be looked after later. So several studies have shown clearly that hypothyroidism by itself does not pose an increased risk for
So thank you very much. I'll hand over